We're live. Yay.
Hooray!
Hooray.
Hello.
No, I don't think anybody's on yet.
Oh, okay. We
That's
can
all
give
right.
it a
We'll
minute.
give it a minute. Oh, there's someone on.
Oh, perfect.
There's a chat there.
I know we want to make sure we can see anything that pops up in the chat.
Yeah. So if you're live with us, there's a chat so you can ask us questions. Feel free to say hello in the chat if you're here. All right. Well, we'll get started. Be nice and prompt for everybody who's potentially eating lunch.
It is 12:30.
Yes.
So.
All right. So welcome to our Live and Learn. My name is Dr. Amy Meridian, and I am a physical therapist at Goat Physical Therapy and Wellness. And I am with...
I am Dr. Allison Calusi. I am here at Goat Physical Therapy and Wellness with Amy. We are colleagues here, and we both treat pelvic floor dysfunction and see patients here for it. So today we are going to be talking about urinary incontinence. It's probably the hottest topic of all topics in pelvic health when we start talking about pelvic health. So we're going to give some background and hopefully answer some questions.
Yeah. So today we're going to stress and focus on urinary incontinence. There are a couple different types of urinary incontinence. There's urge incontinence and there's stress incontinence. And I think the biggest thing for people to remember is that urinary incontinence can affect anyone. And it can happen to people who are pregnant, postpartum. It can happen if you've had some type of surgery. It can also just happen to you because you're aging. And then there's an area of people that don't really think about it as much, and that's our athlete population. And there are different reasons to have incontinence. A lot of times you hear about like the coughing and sneezing, running, jumping. But then there's also incontinence that comes with like the urge incontinence. It's like the gotta go right now people, right? So we're going to kind of dive into those and ways to treat it and what we can do to help you as well from a physical therapy standpoint.
Yeah. So as Amy mentioned, not only are there different types of incontinence, but there's different populations that it affects. And while people think primarily post-surgical, post-prostatectomy, aging, this can happen. You can see incontinence in young people. You can see incontinence in very, very fit people. And any person experiencing any level of incontinence, we still categorize it sort of the same way. Oftentimes I'll be in conversation with someone and they'll say, oh, like, thank goodness I'm not incontinent. I knew someone that was, or my mom or my grandma. And I'll dive a little deeper and say, okay, so you never experience any urinary leaking, no drops, no like just small amounts of leakage. And they say, oh, well, yes, I do, but it's not full bladder loss. It doesn't matter. Yes, full bladder loss is obviously, very known to a lot of people and, pretty shocking and frankly, kind of traumatic. No one wants to experience that, but any amount of urinary leaking is not considered normal. And what we want people to know is while that many people will choose to live with it, either because it's embarrassing or kind of taboo to talk about, or they don't want to bring it up, or aren't sure who to turn to or where to ask, there are options, and there are very approachable options that don't start with medication necessarily or surgery or something that sounds scary or a lot to handle, physical therapy being one of them.
So we're not scary.
One of my biggest soapbox in the world is just making sure that people know that physical therapy for pelvic floor dysfunctions, many dysfunctions, but like we said, today is about incontinence, knowing that it exists. So I'll shout that from the rooftops.
Absolutely.
Forever. So types of incontinence. Most people, when they think incontinence, they typically think stress incontinence. It's a very common experience, a leak that happens with some sort of stressor to the body. So that's what we're going to talk about first.
Sure, let's go. So a lot of those stress incontinent episodes happen, like Allison said, with some type of stressor, and that's your coughing, your sneezing, your jumping, laughing, any of those. Running is another big one. So those are going to be the activities that could cause stress incontinence. And it doesn't even have to be like the second you start running. I've known runners that are training for marathons, for example, and they get to the point where they're at 13 miles, and that's when they start having incontinence. And then the rest of their marathon, they're struggling with it. And so we will work with people across the border of, no matter if it's every time you cough or if it's only if you get a bad coughing fit when you're really sick, to those runners. Gymnasts have a lot of stress incontinence as they're bouncing on the mats and on the floor. We'll work across the board with all of those people with that type of stress incontinence.
Yeah. When I describe it to patients, I talk about stressors as just being a mismatch of pressure in your body. So either there is a force coming down in your body, that's usually something coming from the chest, breath holding for some reason, a cough, a sneeze, a laugh. But whatever that force is puts pressure down onto the bladder. Or there's a force coming from underneath, landing a jump, landing, running, anything where the body has to take on that sort of shock of being hit by
whatever it is,
the end of gravity, coming back to Earth. So in both of those situations, wherever the stressor is coming from, right, the body, the muscles of the pelvic floor need to be able to match that stressor, to meet that pressure change. And if they are, then great, you're probably not experiencing any sort of urinary leak. And if they are not, then that's when people have an issue. And one thing that I always emphasize is that oftentimes, especially in people who are deconditioned or know that maybe they're not exercising as much as they did at one point in their life, or they're, just feeling less in shape, their perception will be like, oh, my pelvic floor is just shot. It's just gone. It's not gone, I promise. No one removed it from your body. But when we say pelvic floor, we're referring to a group of muscles that sit deep in the body. They have many functions, but one of their main functions is maintaining both urine and fecal continence. And so just because these muscles are not able to meet that stress pressure that's put on the body appropriately doesn't mean that they're completely gone, dead, out to lunch. They might be a little bit weak. They might be functioning fairly well, but not in the right timing, not at the right
moment.
At the right moment. I tell people, for all you know, you have a pelvic floor that squeezes and engages just as needed 0.5 seconds after you sneeze. Right. It doesn't matter. You missed the sneeze. So figuring out ways to get those muscles to not only engage and create the correct pressure, but do it in the correct timing sequence is a big part of sort of how we dive into treatment.
Right. And that's really where physical therapy will come into play, is figuring out exactly what's going on with your body. So you're going to come in, you're going to be like, oh, every time I sneeze, like I have this issue. And so we're going to be able to assess your pelvic floor and figure out, is it a timing issue? Is it a weakness issue? And then what do we do for that? And the treatment is different depending on what's going on. But the reality is that there is treatment for it. You don't have to live with these symptoms. We can help you not have them.
Yes. And we should just say now, so that people know, is that while not everyone is aware that pelvic floor therapy exists, if it is a concern that you're having, you can always ask a doctor about it. But also in the state of Connecticut, there are direct access options, which means that you could, knowing that you have an issue that would be helped by physical therapy, seek out physical therapy on your own. You don't need a doctor to tell you to go. So if, same thing, if your shoulder's hurting and you just want to go get it checked out and evaluated by a physical therapist, you're allowed to do that.
Except if you have Medicare. If you have Medicare, you do need a referral, but that doesn't mean you can't call us and talk to us and ask us about anything before you go talk to your doctor.
Yeah. If people come in our door and we know that there's something that we would need from an administrative purpose before we see them, then we let them know. But there's even that, it's a big piece of education that we have that we want to make sure is available to the public, to know that these are options, this is available, and we're always happy to answer questions.
For sure.
People will, people often wonder, well, what does pelvic floor therapy look like and what are you doing? And there are parts of it that looks like other physical therapy and there are parts of it that doesn't. We are able to assess the muscles of the pelvic floor. This can be done both internally in the body or externally. But then as we figure out what's going on with them and what we need to treat, we're looking at things that you would do in many other physical therapy situations: breathing, posture, exercises, both for strengthening and for coordination. And then, like Amy said, in a situation where a runner is leaking far, far, far into a long run, looking at things like balance and coordination of the system, the whole power, the endurance, power, possibly.
And if you remember, we mentioned too that your pelvic floor is like down at the base of your body, right? And it's kind of like a sling of muscles kind of holding everything in. Just above all that, at the top, like right at your diaphragm, I'm going to stand up so you see. So here's your diaphragm and your pelvic floor is down lower. You've got this.
It's hard to do in the screen.
Yeah. Here we go. Okay, there it is. All right. So you've got these muscles on the top of your diaphragm and the muscles on the bottom of your pelvic floor. This right here is your abdominal canister, right? So you've got your abdominal muscles, you've got all your organs, and you've got your back muscles. And something with your back muscles and your abdominal muscles can also be off, causing issues with your pelvic floor, because again, that pressure, if the abdominal muscles are pushing down too hard because they're weak, that can also cause that breakage of the pelvic floor. So we're going to look at all of those things as physical therapists. We try not to be tunnel visioned of someone coming in and saying they have incontinence and just focus on the pelvic floor. For the same way, a runner coming to me with hip pain, I'm not just going to look at her hip. I'm going to look at her back, her hip, her knee, and her ankle. We have to look at everything because everything overlaps each other and everything is interconnected.
Yeah. We mentioned, in the beginning, the common types of patients that we would possibly see. People think, incontinence, maybe post-prostatectomy, postpartum, during pregnancy, because of, as Amy was describing, the pressure system is in the body. Certain people who, we talked about athletes, but another huge piece is anyone who is in music. I have seen both instrumentalists before, anyone who is, and vocalists. Because as musicians, people are trained, especially as a vocalist or someone who is using like a woodwind, for example. If you are using your abdominal wall and your diaphragm to create pressure, to create whatever air you need to make music, the pelvic floor could be having undue pressure put on it as well, or not be as coordinated with the rest of the system as we need.
Because you're so focused on your musical thing, you're not thinking about your pelvic floor.
Right. And then you go to do some other sort of movement exercise, some sort of cross training for you as a vocalist maybe, and you notice, oh boy, the pelvic floor is not keeping up the way that I need it to. Yeah. So much of what physical therapy looks like for these patients can be, out in the gym doing exercises. Sometimes we're a little more nitpicky because we're looking at how certain muscles are engaging and coordinating. But We promise it's not scary.
Not scary at all, because we're not scary.
No.
So we're going to switch gears from stress incontinence, and we're going to talk about urge incontinence next. So I'm going to let you start with that.
Oh, urge incontinence is one of my absolute favorite things to treat. And urge incontinence is when people leak due to an overcoming sensation of an urge. They will tell me things like, I have a tiny bladder, I just can't hold it, I go very frequently, I drink a lot of water. And sure, you may drink a lot of water. That's usually really good. Oftentimes people will think that these things are hereditary. Oh, well, my mom emptied her bladder a lot, or it's my whole family is like this. However, it is much more likely that it is a habit that you picked up from your family as opposed to the actual genetic piece. So urge incontinence is absolutely infuriating because oftentimes it will start before an urge. You won't even know, or you won't even feel that you have to go to the bathroom. And then suddenly when you feel it, that urge hits you smack in the face. Mm-hmm. There is nothing else you can focus on. There's nothing else you can think about, and you are sprinting to the bathroom. Often these people find that leaking occurs as they're just about to enter the bathroom, just about to sit on the toilet, just about to pull their pants down. Sometimes urges arrive when your body is sort of in its get comfortable mode. There's something that we call key and door syndrome, where you're driving down the street and you're not really paying attention to anything, and you're about ready to turn in your driveway, and all of a sudden your body recognizes that it's home, and you start to notice an urge. You walk up to the front door, you put your key in the door, and it's like, I need to go right now. You're running in, your coat is on the floor, your shoes are half on, half off, and you are cross-legged hobbling to the bathroom. And I always ask people when they describe that situation for me, well, say you were coming home from the store. If you had left the store 5 minutes earlier, would it have made a difference? And the answer is usually no, because that urge doesn't have as much to do with the actual timing. How long has it been since you last emptied your bladder? That urge is a trained pattern that annoyingly your body picked up somewhere along the way that associated home, bathroom. And so regardless of how full your bladder actually is, when you last had something to drink, or if it was something that was irritating or triggering to the bladder at all, you are still going to get that signal. Now, it doesn't mean that your bladder is not full. It doesn't mean that, oh, maybe it has been a few hours since you last emptied your bladder and this is an appropriate time to go. Mm-hmm. What it means is that urges are being missignaled somehow through your body. Your brain is interpreting this as a much, much more immediate event than it needs to be. Because in reality, urges should present gradually. You get that first initial, like, someone will say the word bathroom or say, I'm going to the bathroom, or you'll walk by a bathroom and you kind of do a body scan and you notice, like, no, I'm good. Yeah, I'm fine. Yeah. And then you should get to a level of like, oh, my bladder's kind of full. I'm going to stop when's convenient. I have a meeting for another 20 minutes. You know what? I'll stop and go after that. If you put off these urges, you will keep getting louder and louder signals, which is what I call like high level, pull the car over on the side of the road sort of thing. But it's most normal and most liked by our bodies if we empty the bladder when there is a signal, but not when it's at that high level of screaming you on the highway. What can happen is if you are paying so much attention to urges, or if you're getting urges because your bladder is not truly full of volume of urine, but it's irritated by something else. We'll talk about that in a second. But if you are getting that, then your body thinks that it's a much more pressing issue than it is, and it's forcing you to need to go. And sometimes with that habit of having so much urgency, It's so overcoming and so sort of threatening to the body that you end up with a leak. And in these cases, it's much less likely that that leak was because your muscles aren't strong enough or they're poorly coordinated or something that's sort of a more biomechanical imbalance. And it's more so that your body just kind of decided that it was overcome with this and you need to go
It's
immediately.
it's a brain bladder connection.
It's a brain bladder connection. I tell people all the time, you are in control of your bladder. I tell people your bladder is like a toddler. It wants what it wants when it wants it, and it wants it right now. And if you give in to that, imagine if you had a 2-year-old who every time they asked for a cookie, and you gave in and gave them one. And then suddenly you decide, no, we're going cold turkey. I'm going to train you. Well, your bladder, if you say no, I can't go to the bathroom right now. I'm not able to.
Right.
It's the signal is going to get louder and louder and louder and louder. And it doesn't mean it's because it's about to explode. It doesn't mean because it's possibly truly at its fullest form. It just means that you're trying to change a habit. But cold turkey, like I said, you can change these habits, which is why it's my favorite thing to work on with patients, because it's challenging. Changing habits is hard, but my patients usually come back after our first long conversation together about this, and they admit that it worked. The suggestions that I gave them, we talk about spreading out your fluids, still drinking a lot of water, because believe it or not, one of the thing we know what can be irritating to the bladder, anything with caffeine. Most people know that, oh, my coffee,
it triggers me to go.
It triggers me to have to go. I
Yeah.
drink my cup of coffee,
It has
and
an inflammatory effect.
I am urinating a couple extra times over the next few hours. Other things that are triggering for some people are anything that's acidic, things with bubbles, things with artificial sugars. Therefore, diet sodas are kind of a triple threat. And some people, those give them a lot of urges, the caffeinated ones. But what people will do often if they have urgency or if they have leaks with urges is they'll drink less, because they'll think, oh no, like I don't want to have this leak on the way to the bathroom. I better not put as much into the system so my bladder's not that full. When in reality, something that can also be incredibly irritating and triggering to the bladder is more concentrated urine. So as backwards as it sounds, it is smarter to drink more water. You can't just, again, pick it up immediately, kind of breaking your habits cold turkey, and chug 80 ounces of water and think that you won't have to go to the bathroom 20 minutes later. But we make plans and schedules with people for sort of what feels comfortable for them, mentally and emotionally, and what they're willing to try, what their schedule looks like when a bathroom is most easily available to them during the day. And ultimately we look to get to people to like normal voiding intervals, which are every 2 to 4 hours during the day, both so that they aren't constantly bothered by having to take a break from their lives and go, and so that they are confident that they can make it and are not feeling urges too strong or leaking when they're on their way.
Yep. And then there's the nighttime side of urge incontinence too. So we refer to that as nocturia. And that is just that your body is waking you up a lot of times during the night to go to the bathroom. And so there's obviously, like, you can withhold fluids before you go to bed, and that can help with that a little bit. But again, it's all part of the same thing with urge incontinence, is kind of retraining your bladder to not go to the bathroom as often during the day will also help with the nighttime as well.
Yeah. Our bodies are designed to be able to hold the bladder for, 8 hours overnight in bed, and we're not drinking fluids excessively during that time.
Right.
Textbook wise, people will ask all the time, well, I get up and go. And a lot of that is habitual too. And it's hard. It's the middle of the night. If you're sort of roused from the sleep cycle, depending on where you are in your sleep. You know, the second your brain is awake, sometimes the first thing it goes to is like, oh, do I have to go?
Right.
And I will encourage people to try to go back to sleep initially, because then if you do, you're lucky, great, you didn't have to get up and go. Technically, by the book, it is considered normal if you're voiding once at night over the age of 70. But until then, no, I mean, you don't have to if you're over 70, but know that, you know, for some people it happens, but if it's something you're struggling with, or it's interrupting your sleep so much that you know, are tired all the time and not getting enough sleep because you're getting up so many times, there are things that you can do during both the day and nighttime that we can advise in physical therapy to, make changes for that. Yay. The last piece that I want to touch on is about skin health, because while we are very pro come to physical therapy, fix the root of the problem, we'll walk you through the whole thing. For people dealing with incontinence, you know, I don't have any overnight fixes, unfortunately. It's a
There's
journey.
no magic wands.
Yeah, I haven't graduated from Hogwarts yet. Maybe someday.
I'm going.
That'll be what my wand. Good for you. That'll be what I ask for my wand to do. In the meantime, while you're dealing with incontinence, whatever it is, however much it is, if you're using some sort of protection, if you're using sanitary pad, if you're using some sort of absorbent, liner, diaper, absorbent, it should be designed for urine. Sometimes people will just pick up whatever pad there is. There is a difference between incontinence pads and menstrual pads. They are created with like different fibers and absorb differently. And you need to be using something that is for incontinence. They make disposable ones. They actually make reusable ones. There's even like washable, reusable underwear that is fits and feels like normal underwear, that has a liner in it that is incredibly absorbent and can hold up to, usually it's like 2 teaspoons of liquid. But you need to make sure that you are using and wearing what's appropriate for your situation, because if you are not, and there is like moisture through the genital area, you're at risk of skin breakdown and possibly leading to an infection, and no one wants to deal with that. It's uncomfortable and
makes you go to the bathroom more if you end up with a UTI.
Yeah. So make sure that, you know, hopefully you come to physical therapy and we find the root cause and, you know, make the connections that we need to make there so that you are not leaking. But in the interim, or if it's something that you know you're dealing with for a short while, protect your skin health.
Yeah, for sure. All right. So that kind of sums up our TED Talk, if you will, today on incontinence. You can find us at Goat Physical Therapy and Wellness. We are located in Gales Ferry, Connecticut, www.goatpt.com. Please feel free to reach out to us through the website. Our phone number, our contact information is on there if you have any other further questions. Thanks so much for coming today, and we hope you have a good day.
Bye.